Hello, my name is Mark Wall. I'm going to be doing a presentation today on diabetes. I feel like diabetes is an important issue of our time because it's such a problem nowadays in healthcare, and there's many chronic illnesses that stem from diabetes in itself. So we'll get started. Anyway, diabetes is a problem with glucose regulation. Basically, in a nutshell, there's several forms. I decided to do my presentation on type 2 diabetes, which is, I decided to do it on type 2 diabetes because that seems to be the biggest problem I see in the clinical setting. With type 2 diabetes, it's basically what happens is you have a problem with glucose regulation. The glucose is the pancreas is not being able to either send out enough insulin, or you have decreased insulin sensitivity. The thing I found when I was doing my research with the literature, glucose is needed for your cells to have energy. Insulin is needed to facilitate the uptake of glucose into the cell for energy. This process is not working well with type 2 diabetes, and it can be from several factors. But anyway, we'll get into all that. And glucose builds up in the bloodstream, and when glucose builds up in the bloodstream, it can cause a variety of issues. Anyway, next slide.
I just changed. What is the next slide?
Type 2, this type of diabetes is the most common. This disorder is characterized by the lack of insulin, like I was saying, and your body either resists the effects of insulin or it doesn't make enough insulin. And there's several treatment options depending on what the cause of the high glucose is. Next slide. The thing that about type 2 diabetes is it can cause either by genetics or environment, your lifestyle. You can have a genetic predisposition to diabetes, or you can also have environmental factors as well. Like, for example, lack of exercise, overweight, eating the wrong things in your diet, not eating enough complex carbohydrates. These things are some of the environmental factors that can cause type 2 diabetes. And anyway, that's some of the pathophysiology of it. There has been about 65 genes that have been associated with type 2 diabetes. And there are several genetic predispositions as far as the genetic component that can make someone predisposed to diabetes. Also, your greatest risk for developing diabetes is something they call metabolic syndrome. It's basically where you have central obesity, dyslipidemia, and prehypertension, and elevated fasting blood glucose levels. Next slide. The risk factors for type 2 diabetes, like I said, are obesity, fat distribution, more fat in the abdomen than fat distributed elsewhere. That increases your chances for diabetes. Inactivity, not living an active lifestyle, being overweight, that's another factor. And different races have different genetic predispositions to it. For example, there's a higher incidence among diabetes among Hispanic, American Indian, and African American community. And your age also, the older you get, the more you can have problems with regulating your blood glucose levels. And polycystic ovarian syndrome has also been associated with type 2 diabetes. Prediabetes, gestational diabetes, like I said, inactivity and sedentary lifestyle, and a family history of it are all risk factors for developing diabetes. The symptomology, what do we see with diabetes? Well, polyuria. That's basically where you wake up in the middle of the night and you gotta pee a lot. And polyphagia means you're hungry all the time, and polydipsia, which means you're thirsty all the time. And you're thirsty because the water, when you have a high blood glucose levels, through osmosis, you're pulling water out of the tissues into the vascular system, and you're having to pee. And we see things, when we have this happen, we can see urine, we can see several things: ketones spilled in the urine, and we can also see glucose in the urine, because our kidneys actually reabsorb the glucose, and when we have more sugar in the bloodstream, it causes the kidneys to, it bombards the kidneys, and it overloads those transport cells that transport the glucose from the kidney tubules back into the bloodstream, and so the glucose, they get overloaded, and so the glucose spills into the urine. So like I said, we're frequent urination, constantly thirsty. One of the things that diabetics have is that the thing we see with diabetes is it causes nerve problems, because we can get neuropathy from it, because the high blood glucose levels is not good for our nervous or central nervous system and peripheral nervous system. It causes the central nervous system has to have some glucose, but it can hurt the neurons if you have too much glucose in the system. And when you have this, you'll see tingling in the feet and the hands, and we'll see weight loss. The reason why we see weight loss is because when the body cannot transport glucose into the cell, that goes for alternative fuel sources. The alternative fuel sources that we see with diabetes is fat and then protein. We see fat first, and so what happens is when the fat breakdown, when we have fat breakdown, because the glucose is so high and we can't bring glucose into the cell, so the cells start breaking down fat, is we get a byproduct called ketones. Well, the problem with ketones is they make the blood more acidic. It lowers the pH of the blood, so you'll see elevated breathing with it, and you'll see the lower pH of the blood. So that's one thing we'll see. You'll also be hungry. We talked about that. Another problem that we see with type 2 diabetes is slow healing. Well, the reason why we have slow healing is because we have decreased circulation, because the way it was explained to me one time is the glucose molecule is kind of like a sand spur. So as it goes through the blood vessels, it causes these little niches in the blood vessels, and you get scarring, and so you get vascular remodeling with it. So that's, and we get the slow healing because bacteria like to feed on sugar, and so you get slow healing because your body is not able to combat the bacteria, because bacteria have like a fuel source to grow. So anyway, that's why you see slow healing. And then you can also see blurry vision. Well, the blurry vision goes back to the neuropathy. It can attack the retina, and that's where you get the blurred vision, is the optic nerve, the retina, and all that. That's where diabetes, once again, attacks the nervous system. Another thing, like I said, nerve damage, kidney damage. That's probably the biggest thing with type 2 diabetes. If you don't regulate it, there's two things that kill the kidneys. One of them's diabetes, high blood sugar. The other one's hypertension. We won't go into the hypertension aspect of it, but the diabetics with the blood sugar, like I said, it decreases the problems, or it hurts those capillary corpuscles of the kidneys and capillary beds of the glomeruli in the nephrons, and that's where you get the kidney damage from. And then you also have increased risk for dementia, and so eye damage, we talked about that. Heart and blood vessel disease, decreased circulation, problems with, you can see arrhythmias as you get older with the problems with diabetics. And then you can also see skin conditions with this. Anyway, moving on next one. How do we diagnose diabetes? Well, there's several ways we can diagnose it. We can diagnose it through laboratory tests, fasting glucose. We can diagnose it through urinalysis. We can diagnose it through hemoglobin A1C. That's probably one of the bigger ones, because the hemoglobin A1C is testing, hemoglobin molecule lives about 120 days. It's like how a red blood cell lives. So what happens is as that red blood cell goes through there, the more sugar you have in your blood system, it can actually attach to the hemoglobin molecule, and you get glycosylated hemoglobin, and it gives you an average of what your average blood sugar level has been over the last 120 days. So it's actually a good marker for how well you are managing your diabetes. Anyway, another way is fasting blood sugar test. If it's less than 100, it's or it's normal. If it's 100 to 125, it's pre-diabetes. If you're 126 or higher on 2 separate occasions, that's a diagnosis for type 2 diabetes. We can also do random blood sugar tests just to see what you do after you eat, or before you eat. So all these things compiled together can give you a diagnosis of diabetes. You can also do an oral glucose tolerance test. That's basically where you have 2 hours. We measure how much your glucose, how much it spikes, and then how it goes down and how fast it goes down. And the indicators for that is after 2 hours, if it's less than 140, it's normal. If it's 140 to 199, you're pre-diabetic. If it's greater than 200, it's diabetes. Treatment. How do we treat diabetes? We want to see if your diabetes is caused by environmental factors. We would like to try and change that. So, for example, if you're overweight, we want you to lose weight. If you don't get enough exercise, we want you to exercise 3 times a week. We want you at a normal BMI. And we can also treat it with oral diabetic medications like metformin, glipizide. These things help to regulate our blood glucose levels without having to take insulin. The next step would be, if these don't work, we can either continue them and take insulin, or we can take insulin altogether. And we got several types of insulin. You got rapid acting, regular acting, and long acting. An example of your rapid acting would be like Humalog insulin. An example of just your regular, intermediate acting, it would be like your regular insulin. And then your long acting kind of helps you regulate it over a 24-hour period. That'd be your Lantus or your Levemir type insulins. We also want to, when we're being treated for diabetes, we want to monitor our blood sugar. We want to tell our patients that they need to be checking their blood sugar every day, and they need to be logging it and to see kind of what we're trending, so the doctor or the nurse practitioner knows how to adjust our insulin or medication levels and stuff like that. So that's how we treat type 2 diabetes. Next one. I have a case study. So you got a 55-year-old Hispanic male. She's got a BMI of 32. When she had a child, she had gestational diabetes, and she lived a sedentary lifestyle, and her hemoglobin A1C was 10, and her fasting glucose was 150. I saw this in clinical practice, and what this is, she's got a risk factor already for being Hispanic, because there's a genetic component to it, and Hispanics have a higher incidence of diabetes than some other races of people. The BMI, this also puts her at risk factor. She's overweight. She lives a sedentary lifestyle. She doesn't exercise. And she didn't smoke, but if you are a smoker, that can help contribute to diabetes. Studies have shown that. But her fasting glucose is 150. All these criteria right here, the risk factors, the sedentary lifestyle, the chemical markers, the hemoglobin A1C of 10, the fasting glucose of 150, all these are indicative of a diagnosis of diabetes. Next slide. This patient used a daily blood glucose monitoring device. She's also on metformin therapy and insulin therapy, both rapid acting, PRN, and long acting daily. She realizes that she needs to exercise but does not on a daily basis. However, she has changed her diet by counting her carbs and eating more complex carbohydrates with fiber. That's important. The reason why that is important, if you eat simple sugars, you bombard the system, and the insulin has to crank out, your pancreas has to crank out a bunch of insulin. And when that happens, that leads to very unstable blood glucose levels. What we want to see in a diet is where we eat complex carbs, where our body has to digest it more, so you get a gradual increase in your blood glucose and not a surge in it. And then the fiber kind of helps with that as well. So that's what we try to teach our patients, is change your diet to try and lower your risk for diabetes. there is no inconsistencies with this case study when compared to the research literature for treatment and diagnosis of diabetes. This patient had multiple risk factors for the development of diabetes, and the way this case study will impact my nursing career by allowing me to recognize people at risk for diabetes. That's the most thing. You can kind of recognize the risk by looking at all the risk factors, environmental and genetic, and that's what tries to help me educate my patients. I know which ones are more prone to being at risk for it and try to teach them how to eat healthy, how to live a better lifestyle as far as exercise, how not to smoke, you know, to teach our patients about diabetes, the pathophysiology of diabetes, why diabetes is not to have diabetes is important, why it's important to regulate our blood glucose levels. And the reason why is because we don't want all these chronic conditions, and we want to teach our patients that. We don't want kidney disease, we don't want nerve disease, we don't want poor healing, skin conditions, the main one I think is kidney disease. Who wants to go be on dialysis 3 days a week? I certainly don't. And so it's important that we teach our patients who don't know about this kind of stuff that it's very important for the blood sugar to be regulated, and important to lose weight and live a healthy lifestyle so that we can be the best person we can be. We want to educate them on the disease process, how to mitigate these risks, and how to try and curb diabetes if you're prone to it, especially if you have a genetic component to being predisposed to diabetes. And that's excellent. And that's basically it. That's all I have for my presentation today. Thanks.